Hello, today's topic is on history taking in pediatrics. History taking in pediatrics differs from the adult history taking because it relies on information from caregivers and requires careful observation of the child. So before you start taking a history, you should have a good approach. First, you should introduce yourself to the parents or the guardians, then gain confidence of mother and child, look interested and then smile, maintain eye contact with child and the guardian, and try to avoid scribbling notes while you are talking to the parents. Take a complete history, then you can write your history. Many times what students do is they just go on scribbling in the notes while they are talking to the parents. So you should not be doing this. Now come to the format of history taking in pediatrics. First I'll tell you the headlines, and then after that I'll try to explain each points. So while taking the history, you start with the particulars of the patient, then you ask for the chief complaints, then history of presenting illness, then comes past medical history, then you talk about the birth history, prenatal, natal and postnatal, then you take a dietary history, then developmental history, followed by immunization history, medications and allergies, family history, social history and personal history. So now I'll be describing each point in division. Starting with the particulars of the patient. Here you take the identity of the child. You ask for the name, age, sex, religion, address, date of admission, date of examination. Then you ask about the informant, whether they are parents, grandparents or school teachers, and many times children come from the orphanage. So the guardians from the orphanage can also be the informant. So based on this informant, you can state how reliable your history is, whether it is good, fair or poor. Because orphanage guardian cannot tell detail about the birth history because they bring the child maybe later, maybe at 2 years or 3 years, then they can't say about the development of the child also. So history is not going to be so much reliable. If it is from the parents, that will be reliable. Then comes the chief complaints. Chief complaint is a brief statement which states what has brought the child to the hospital or to the doctor. Then you ask about the complaints, the onset of the complaints with a duration. Suppose child has fever and cough, then you are supposed to write fever for 5 days, cough for 3 days. So this way, onset and duration. And then this should be recorded in a chronological order. Suppose fever is for 5 days, cough is for 3 days, then you write fever for 5 days, then cough for 3 days. Then the history of presenting complaints. In pediatrics, the history of presenting complaints are of different types. It can be, number one, it can be acute illness. This means the illness lasting for just few days. Fever for 2 days, cough for 2 days. So this is acute illness. Another pattern is, it can be moderate illness. Example, loose stool 10 days ago, vomiting 6 episodes since morning, and seizure 2 episodes in 2 hours. So the patients, they don't come when the child is having loose stool for 10 days. But when the child starts having seizure, 2 episodes in 2 hours, then they come to the hospital. So this can be one pattern of the chief complaints. Third, a child may be having chronic illnesses like nephrotic syndrome, bronchial asthma, SLE, febrile convulsions. So these illnesses which are having a relapsing and remission course. So this type of pattern you need to approach differently. Then some illness is there which starts since birth. Examples: Down syndrome, other chromosomal anomalies, or cerebral palsy, which starts very early in the life. Then fifth type, the child may come present to you with a loose stool or diarrhea, but when you examine and find, you may see this child is also having malnutrition. So these are these different patterns of presenting complaints which can come to you in pediatrics. So each cases you may have to approach in a bit different way, but the basic will be same. So once you take history of presenting illness, suppose the complaint is fever and cough, then first number is you should elaborate the chief complaints with the associated symptoms. Then second step in the history of presenting illness, you review the systems, the points which was not mentioned in the complaints. Then you write a progress note. That means progression of this illness in short. So these are the 3 points you have to focus on when you are taking history of presenting illness. So we start with elaborating the chief complaints. While elaborating chief complaints, it should be like you are telling a story. You talk about details of the presenting complaints respecting the chronological order. Always start with the statement, patient was asymptomatic so many days ago. Then you start mentioning the complaints. Or you can even say, the patient was well until this date. Or you can say, history of this child dates back to this day. And then that way you can start elaborating your chief complaint. Always try to use patient or guardian's own words. While presenting the history of presenting illness, you should not use any medical terms. Each complaints, the common complaints I'll be discussing later how you're supposed to elaborate, but each complaints, this is a general rule. For each complaint, you can describe it this way. First, you'll say onset, whether it was acute, insidious. Then you talk about the duration, frequency or character of that complaint. Then you say mention the severity of this complaint, whether it is high grade, moderate or low grade. Then you talk about the associated symptoms. Suppose if you say fever, associated symptoms can be chills, rigor. So this way. And then you talk about the diurnal variation of this complaint, any aggravating or relieving factors for the complaint, and postural relationships. Many times you require postural relationship of these complaints. So this is just a general description for any complaints. Then second point in the history of presenting illness was reviewing the systems and then talking about the negative history. So when doing this, it is serving a checklist for you, giving you information that might have been missed out. And it gives you information from systems which was not presented in the history of presenting complaints. Then you ask some negative queries. Negative queries you are asking. Negative queries and systemic reviews when you are doing, you are usually giving a leading questions. But when you are talking about the history of presenting illness, elaborating the complaints, here you are not supposed to give any leading questions to the parents or guardians, to the informant. So when you're asking the negative queries, you're trying to rule out the differentials which are very similar to these complaints, so that you can come to a best diagnosis, and also to know the severity and complications of that presenting illness. You are going to ask few questions. Suppose this is a case of diarrhea, then you can say there is no decreased urine output. So that will be indicating severity of the dehydration of diarrhea. or that can be complication also. So this is just an example. And lastly, you'll talk about the progress note. So here you're going to mention the patient's general state during the illness, soon after illness, what these parents have done, taken this child to some medical shop, taken some medicine or not, and then medications and treatment given for this illness. So from the shop they get some illness and then they do not improve, then they come to the hospital. And after admission, any new symptoms during the illness. After admission, whether new symptoms have developed. So those you can explain in the progress note. Then how is the child now? When you're taking the history, how is the child? Suppose this child was admitted 3 days ago and you are taking the history after 3 days, then you can ask how is the child at present after admission, whether the child has improved, deteriorated or is remaining same. So all these points are going to help you to come to a diagnosis. So this progress note should be taken in short. Then come to the past medical illness or history of past illness. So here you ask about any major illness in the past requiring any hospitalization, any major surgeries, recurrent or prolonged illness, if the child is on any medications, or if the child is having any allergies to the drugs, food, or child has hay fever or asthma. And then ask about the common childhood diseases like pneumonia, diarrhea, measles, rubella, pertussis, mumps and varicella. Now come to birth history. It's very important for the first 2 years of life. So till 2 years of life, detailed birth history is essential or it is a must for all children. Beyond that, sometimes you can take a shorter birth history, but this is always important in a pediatric history taking. So we start with the antenatal history. During pregnancy, this signifies during pregnancy the mother's age, health, if she has a chronic disease, nutritional status, medications, any vaginal bleeding, toxemia or exposure to radiation. And mother's weight gain excessive or insufficient, number of previous pregnancies, whether there was any bad obstetrical history, results of serology and blood group of mother, foul smelling discharge, and any fever, infections or rash in the mother. Then ask about the antenatal checkups, whether it was a booked or unbooked case. If booked, where the checkup was done, and frequency of visits in the booked case should be during the first trimester 1 visit, second trimester 2 visit, third trimester 3 visits. If the mother was immunized for tetanus, whether she had taken iron, folic acid, calcium supplementation or any other drugs taken before delivery. This should be asked in detail. Then birth history, during the natal history, place and mode of delivery, whether it was a normal vaginal delivery, instrumental or cesarean section. Duration of labor is important. Immediate cry by Apgar score or in mother's words like cry, color of the baby. Then mode of cutting of umbilical cord, whether it was cut by the trained or non-trained person, how was the umbilical cord tied. Then maternal risk factors for sepsis like prolonged rupture of the membrane, maternal UTI or maternal fever is important. Then postnatally after birth, you should see the gestation age of the child, term, preterm or postterm, resuscitation required. Then basic measurements of height, weight and head circumference. When baby passed urine or meconium should be asked. Then common postnatal problems like respiratory problems, jaundice, sepsis, feeding difficulties, convulsions, infection, congenital anomalies should be asked, and whether this child was admitted to NICU or not. Neonatal intensive care unit is NICU. Then start the dietary history or the feeding history. Here you ask about any pre-lactal feed, before breastfeeding whether any feed was given or not. There are some cultures where they give honey, glucose water, so all these things to the baby which should not be given. Then take history of breastfeeding, whether colostrum was given or not, duration of the exclusive breastfeeding, and then on-demand feeding was done or not. If not breastfed, then age of the formula feeding when it was started, then dilution, amount and frequency of the formula feed, and mode of feeding is important, whether feeding by bottle or by spoon. Then ask about the age at weaning, the type of food introduced, protein and calorie intake per day of the child, whether this child is getting a balanced diet or not, or this child is dependent on fast food. This is important. Whether this child is vegetarian or is taking a mixed diet, and food allergies, especially or on special diets is important. If the child is diabetic, is having a phenylketonuria, that is PKU, or celiac disease, child will be getting special diets. So these things you should ask, and dietary intake before the illness is important. So the nutrition a child should be getting is less than 6 months or till 6 months breastfeeding exclusive. After 6 months to 2 years, a child should get breastfeeding along with complementary feed should be added. Breastfeeding should be continued till 2 years. Then more than 2 years, you do a 24 hours dietary intake recall, and then you have to calculate the calorie intake of the child and the protein intake, whether it is sufficient or not. This average energy was designed by WHO and UNICEF for breast milk and for complementary feed. So if the child is getting this much of complementary feed along with breast milk less than 2 years, then the child is getting adequate calorie and protein. So 6 to 8 months from breast milk, child gets 413 kilocalories, and from complementary feed, a baby should be getting 200 kilocalorie per day. 9 months to 11 months from the breast milk, the child gets 379 kilocalories, and from complementary, when you calculate, the baby should be getting 300 kilocalorie per day. Then it signifies adequate calorie. 12 to 23 months, 346 kilocalorie from the breast milk, and complementary feed, a child should get 550 kilocalorie per day. So you should calculate the calorie from the complementary feed and just add on the breast milk, that is on average. So if the child is getting adequate, then you will say child is getting adequate calorie. Otherwise, if it is less, you will say child is deficient of this much calorie. Expected calorie after 1 year, the method of calculation is as per expected weight you can do, as per age you can do. So as per weight, you follow the Holiday and Sager method. So in this, for the first 10 kg, 100 kilocalorie per kg per day is the requirement of the calorie. That means if the child is 10 kg, 10 into 100 will be 1000 kilocalorie per day this child will require. Second 10 kg, that is 11 to 20 kg, 50 kilocalorie per kg per day is the requirement. So if the child is 20 kg, then first 10 kg was 1000 kilocalorie, second 10 kg you will do 10 into 50, so that will be 500, then 1500 kilocalorie per day will be the requirement of a 20 kg child. So that way you go on calculating. So beyond 20 kg, every 10 kg you add on 20 kilocalorie per day. As per age, when you do first year, a child requires 1000 kilocalorie per day. Then every year you go on adding plus 100. That means a 8-year-old child will require 1700 kilocalorie per day. 9-year-old child will require 1800 kilocalorie per day. 3-year-old child will be requiring 1200 calorie per day. So that way. After that, you take growth and development history. Growth, you're going to measure the height, weight, head circumference and then find out. And then you can ask about the puberty if appropriate to the child's age. Developmental milestones you need to check. You need to check for all the domains like gross motor, fine motor, personal and social, adaptive, language and speech and hearing. So this development in detail I have mentioned in my previous lectures about the developmental milestones in detail. And many times in detail it's difficult to get. Suppose the child is in orphanage and the child is 3 years old, it might be difficult to get the detailed developmental history. So in that case you can just ask about the grade the child is going to, and then performance in the school, academic performance, and then you can compare with the SIBS or the pairs. And here you can ask about the bowel and bladder control achievement also. So that also indicates the development of a child. Next is immunization history. Place of vaccination is important, whether additional vaccines are given or not. One is routine vaccination, another is additional vaccination. Then ask about routine is every child is getting designed by the government, and additional is optional vaccines which later on you add according to the options given and then the family accepts. So that way additional vaccines are given. Always ask for vaccination card if possible. Any vaccine side effects has occurred, you should be asking about this. This is just a schedule designed. Many developing countries, they follow this vaccination. BCG given at birth, then pentavalent vaccine, oral polio vaccine, pneumococcal vaccine, rotavirus vaccine, and fractionated IPV, that is the polio vaccine, at 6 weeks. Pentavalent second dose, OPV second dose, pneumococcal second dose, rotavirus second dose 10 weeks. Pentavalent third dose, OPV third dose 14 week. Then MR, measles and rubella 1. Many countries they give MMR, measles, mumps, rubella. Then pneumococcal third, and then fractionated IPV2 is given at 9 months. JE, Japanese encephalitis vaccine, 12 to 23 months. And then MR second dose, typhoid vaccines at 15 months. And TD for the woman of childbearing age is vaccination schedule. So this may differ from country to country. Then move on to family history. Here you have to ask about the type of family, whether it is a nuclear family or joint family. Parental age of the mother and father, whether this was a consanguineous marriage, that is the marriage in the blood relations, and total members of the family, members in the family, and the number of siblings this child has. Illness in the family, any chronic illness like tuberculosis, hypertension, diabetes mellitus, epilepsy, bronchial asthma or eczema, and any congenital anomalies in the family should be asked. And family members with similar symptoms as the child, is there or not. So many times in genetic diseases they may have this. And then finally you have to make a family tree, that is pedigree up to 3 generations is expected. So when you make a pedigree chart, these are the different symbols you can use for male, female, mating, for consanguineous marriage, for carrier, female carriers, male carriers, and there are symbols for twins, monozygotic twins, dizygotic twins, and if the sex is unspecified there is a different sign. So these signs you can follow. This is just an example of a family tree in a cartoon form I am showing. So pedigree up to 3 generations. So above, topmost is grandparents, grandfather, grandmother. Then comes your father, mother, uncle, aunt. Then about your siblings, sisters, brothers, and then center is me, and then that way you get your cousins from uncle, aunt. So this way 3 generation pedigree you are supposed to make. Then comes the personal history. Here you are going to ask about the personal status. Younger children ask about the nail biting, thumb sucking, breath holding spells, temper tantrums, pica, tics, sleep problems like nightmares, night terrors, Then bladder bowel habits, you can ask in the personal history also. Bedwetting, constipation, or any fecal soiling of the pants, the appetite of the child, diet and sleep of the child, sleep pattern. Then once the child starts going to the school, you ask about the school adjustments, class progress, how the child is doing in the school, interaction with the peers, number of missed school days because of chronic disease. If the child is adolescent, you ask about the habits like smoking, alcohol or drugs. Adolescent females should take the menstrual history also. Lastly comes the socioeconomic status. Here you talk about the status of the house, whether it is sunny, ventilated rooms or not, sleeping arrangement, whether there is any overcrowding, depending upon the number of individual living in the certain space of house, you take out the overcrowding also. Water source, sanitation, any pets in the house, and any disease contact is important. The home condition, like parents, whether they are divorced or separated, whether there are any smokers, alcoholics are at home, which affects the child's growth and then emotional growth also. And ask about the father's, mother's occupation, education, and then total family income, and then just take out the socioeconomic status of the child using the Kupaswamy socioeconomic status scale. So according to the Kupaswamy socioeconomic status scale, they give some scores which you take out depending upon the education, occupation and income. So score 26 to 29 indicates upper class family, that is 1. 16 to 25 is upper middle class family, 2. 11 to 15 score indicates lower middle status family, 3. And then 5 to 10 score gives you upper lower status family, that is 4. And then less than 5 indicates the lower, that is the 5 socioeconomic status class. Okay, thank you. So next class I'll be talking on symptomatology, chief complaints, different common symptoms in pediatrics. Thank you.